for now, but like during like I'll listen to how it goes, like review it and stuff, and then like get some wrong.
Okay.
Uh,
Um, okay, awesome. All right. So basically, I liked between OB and peds, I liked OB more. I don't know, in terms of like learning the material, I really liked OB. Um, but okay. Oh, I also forgot to say, please put your SFC ID number into the chat. Um, I always forget to, I haven't done this in a while. So please do that for me. Um, just make sure you just do it before you leave. But okay, so I'm gonna go over the first few chapters that you've pretty much learned about. One of the things that I want to talk about when we're talking about these like ovarian and endometrial cycles is that even though they seem like two separate cycles, they're very much so intertwined. Um, so, um, when we're talking about that ovarian cycle, we're talking about this period where our body is trying to say, hey, we can have a child soon, and we have to follow this three-phase set. So, um, we have the follicular phase, which is basically when the eggs are developing into the ovary so that they can become more mature. So the way that they become more mature is the follicle stimulating hormone is released to aid in the development of the eggs, right? They're called follicle stimulating hormones. They help stimulate the production of these eggs. Once that egg becomes mature enough, the luteinizing hormone will rupture that mature egg out of the ovary. So it's going to kick it out of the ovaries so that it can go into the process of ovulation. So, what else do we need to know about this phase? Well, it starts from day one of menstruation to day 14. Day 14, or 14 days before you menstruate, is when you ovulate. So, right before ovulation, we have this follicular phase, which I said is basically trying to get that egg, trying to get that mature egg, and then that luteinizing hormone helps release it so that it can fall down and hopefully meet its mate so that a baby can be formed. 14 days before menstruation is when you ovulate. She's going to ask it like that. It's going to be there. And ovulation is simply the release of mature follicle resulting in a drop in estrogen. So essentially what happens here during this ovulation period is that it always occurs, you'll have to know this, 14 days before the next cycle exactly. It's where that mature egg that was released by that luteinizing hormone in the fallopian tubes wants to get fertilized. So as it's falling, it's waiting. That egg is only good for 12 to 24 hours after it gets kicked out by that luteinizing hormone to for fertilization. After that, it's basically useless. Um, as this is occurring, the body is making this corpus luteum or this thickening of the uterus so that the egg can attach there, so that if the sperm and egg meet, the baby can start to form. And that's why we have progesterone increasing in this phase and estrogen decreasing, because progesterone is a pregnancy hormone. So it needs to increase because, hey, we're trying to have a baby in ovulation. So that's the whole point of this. So that's why progesterone is increasing. It is the pregnancy hormone. Um, and some things that you see when or things that progesterone does as a hormone is that it maintains pregnancy. That's why it's released during ovulation. It aids in implantation, right? And the egg needs to implant to the uterus so that baby can start forming. It has hyperthermic effects, meaning the temperature of your body can elevate. That's why, when you ovulate sometimes as a female, um, you could feel heat flashes. It's because your body's also producing that progesterone to increase your body's temperature. It could also have GI effects. So could affect your bowels a little bit, okay? But the main idea is that ovulation is occurring 14 days before you menstruate. That egg is only viable for 12 to 24 hours. And as this is occurring, we have that corpus luteum at the site where the egg was released, which is in the hopes that the egg will implant there so that the baby can be formed. And then we have the luteal phase, which is basically it starts at ovulation and it ends at the next menstrual cycle. And this phase is not really too much asked about. I would just know that it begins at ovulation and it lasts until the next menstruation. And it would also make sense that the follicle stimulating hormone and that luteinizing hormone are the lowest at this point because we need them more in our follicular and our in our follicular phase than we do in our luteal phase. Okay. So we talked about that. We talked about what hormones are, being let out at what times. Oh, also, I just wanted to note that you could have spotting in your underwear during ovulation. But okay, so we already talked about the three phases. So we understand how it works. We understand the importance of each phase. The next thing that we have is the endometrial cycle. And it's like it could, like I said, it could seem like two cycles, but it's not. So when we're having that follicular phase where those eggs are trying to mature, trying to be produced so that it can get ready for ovulation, we have the proliferative phase of the endometrium or the lining of the uterus. What happens here is that as that follicular phase is happening and the eggs are multiplying and maturing, the uterus is getting thicker. Remember, we need the uterus to get thicker for implantation. Estrogen is released during this period. In the secretory phase or secretory, I don't know how people say it, but in that phase, it correlates to the ovulation phase, which we said ovulation is 14 days before your next period. In this, that estrogen is decreasing and that progesterone is increasing because that's the pregnancy hormone and it's making that corpus luteum for that implantation. So the uterus is even thicker because it wants to implant that egg to the wall. So, in just a summary, in this phase, we have the egg released by the ovaries, right, by that luteinizing hormone, and now we're in ovulation. While that egg is dropping, progesterone is being released. So hopefully there's implantation, and in return, in the secretory phase of the endometrial cycle or the uterine cycle, the uterus is getting thicker. Now, if implantation doesn't happen, because that's the whole point of these phases, if it doesn't happen, we get the ischemic phase of the endometrial cycle, which means that we get our period for a female. And that thick wall that we were creating for all of those days is going to shred and cause the bleeding that women experience during menstruation. Is there any questions about those two phases? I tried to combine them so it all makes sense. Okay. I'm going to take silence as no, which is awesome because I want you all to understand. So we also have menstrual cycle hormones, right? We talked about the importance of the follicle stimulating hormone, where we see that primarily in that follicular phase and that proliferative phase, the luteinizing hormone at the end of that follicular phase so that that egg can release out and we can go into ovulation. And what is the purpose? It's a surge results in rupturing of a mature follicle. It's what I said, kicking out that egg so that we can have ovulation. Now we have two other hormones, estrogen and progesterone. Estrogen helps with the maturation or making the eggs more mature. Okay, so if it's helping them with maturity, we're seeing that more in our proliferative or our follicular phase. Those phases is where we see them. And as said, it's predominant at the end of the proliferative phase, preceding ovulation. It has to happen before ovulation because estrogen cannot be as high as ovulation as occurring, okay? And it decreases dramatically after ovulation. Progesterone, right, causes the endometrium, or that sort of lining of the uterus, to get really thick. And we said it's a pregnancy hormone, so it has importance in maintaining pregnancy. It helps with implantation. It has those hyperthermic, right, or increases your body's temperature, and it can cause GI upset like constipation, hemorrhoids, nausea, and vomiting. Okay, that's the most important hormone. You need to definitely know what they do because it definitely will be asked. Okay. Any questions with chapter 3? And as I said, if you haven't put your SFC ID number into the chat, please do that. Okay. So the next thing that we have is chapter 10, and we're talking about how eggs develop, the name, the process, how sperm develops, things like that. There's a lot of important key details that we're going to be talking about here. So we have the ovum, right? We want to make a mature egg, and we do that through oogenesis, which is basically the process that makes this female gamete, meaning ovum and egg. This is where the ovum is that half, right? The 23 chromosomes, only half of what a human needs. A human needs 46. That's when we have spermatoza, where we want to make sperm. And we have spermatogenesis, which is the production of the male gametes or sperm. In one single ejaculation, a male can produce anywhere between 200 and 400 million sperm or spermatozoa. And that makes up the other 23 chromosomes that a human needs. So when the sperm and the egg come together, we get our 46. Fertilization is the process, also can be called conception, which is when the egg and the sperm infuse and we get something called a zygote or a fertilized egg. It could also be called a new diploid cell. Usually we see this in this outer 1/3 of the fallopian tube, and we have a cilia, which is almost kind of like hair that helps it move the zygote towards uterus. But I want you to know zygote means fertilized egg, and it happens in during conception, which is the first 12 hours of when the sperm and the egg meet. Ova or egg is best 12 to 24 hours after ovulation. So once that egg gets kicked out and it's coming down, you only got 12 to 24 hours to get pregnant. If a woman does not get pregnant during that time, the egg is no longer good. Whereas for a male, sperm lasts average 24 to 48 hours, but it is most viable during the first 24 hours, but it can survive up to 72 hours, which means the male has about 3 days where, if you have intercourse during that time period of ovulation, like if you're going to ovulate, let's just say Saturday, and someone and their partner have intercourse that could lead to possible conception, Thursday, there's still a chance that she can get pregnant. So knowing that sperm is most viable for the first 24 hours, but can survive up to 72 is really important. I know that was on my exam. She's also probably going to ask you how sex is determined, meaning XX is for girl and XY chromosome, boy. Okay, know that because I think she will ask a question with that. And just as a summary, so when conception occurs, it'll happen within 12 hours of having unprotected sex. The egg and sperm will meet and it'll become a zygote, that fertilized egg with the 46 chromosomes. Once that happens, the zygote immediately undergoes replication, which basically means things are going to start happening so that baby can start to form, and that's when the sex of the baby is determined. So once it undergoes replication, the sex of the baby is determined. Is it XX girl or XY boy? Um, then we have another important term or idea is gestation. It's this intrauterine development from conception through birth. So basically, when the baby gets implanted, as it's growing, that whole process. That's why they say like 38-week gestation, right? Being pregnant for such and such time. So we talked about conception, we talked about a zygote, we talked about that it goes under rapid um, replication, which will lead to determining the sex of the baby. Within about 7 to 10 days, we get specialized cells of blastocytes and trophoblasts. So blastocytes are this cell that becomes the embryo and the amnion, or that amniotic fluid that surrounds the baby. The trophoblast becomes the placenta and the chorion, which helps support the baby's life. Okay. And the trophoblast and the blastocytes, even though they're separate cells, they adhere to each other. So you have imagine, it's hard to draw, but imagine you have a wall, right? And I draw one semicircle on the wall. That's the blastocyte. Then I draw another semicircle on top of the blastocyte. That's going to be the trophoblast, where that placenta is coming from and things like that. So, something else that I want to share is that the human chronotropic gonadotropin, or HCG, is secreted. And this is how we determine pregnancy tests. This hormone says, hey, you are pregnant or you are not pregnant. And know that embryo, the term embryo, the day we can define the baby as that, is from implantation, which occurs at day 15 after fertilization, through the end of week 8 of gestation. Okay. So the embryo is from implantation, day 15 after fertilization, through the end of the 8th week. The first 2 weeks, it's still considered a zygote. Okay. So, in summary, when conception occurs, the egg and sperm meet. It becomes a zygote of 46 chromosomes. Once that happens, the zygote immediately undergoes replication and the sex of the baby is determined. The zygote's going to divide into something called a morula. I don't know how to say that. But it's basically a solid ball of 16 cells, which is going to lead to those specialized cells of the blastocytes and trophoblasts that we spoke about. The blastocyte will become the embryo, and the trophoblast will become the placenta, which will attach to the baby and the mother through the uterine wall 7 to 10 days after conception. Once the trophoblast implants into the uterine wall, guess what happens? If that baby's implanted, right? Now, once it implants, right, day 15, we have that embryo, we have HCG being released. As soon as that trophoblast hits the uterine wall and connects, the pregnancy hormone that lets us know, hey, they're pregnant, is being released, HCG. Once the implantation has occurred, they become the embryo, which ends up being day 15 all the way to 8 weeks gestation, where we're going to see major organs developing. Is there any questions about this process of conception and fertilization?
Yeah. I guess my question is, I'm a little confused on like, okay, at this point it becomes an embryo. At this point it's a zygote, but at what point does it become a fetus? I guess I'm confused on that part.
Fetus is right after the 8th week. 8th week, one day they're a fetus.
Okay. Okay. And can you just
Yeah.
go over the zygote and just when it becomes a zygote and when it becomes sorry, not an ovum, but like you know what I mean? Like when it becomes a zygote, when it becomes a fetus, if you could just go over that part just really quickly for me, please.
Oh, of course. No, I know it can be confusing. That's why every single point, if you haven't seen so far, I had summaries in my notes because I needed a way to summarize everything for myself because sometimes I got confused. So yeah, so when conception happens or you have unprotected sex and the egg and the sperm meet, it immediately becomes a zygote. It becomes a zygote because now it has 46 chromosomes. Once it becomes a zygote, right, which is right after conception, and conception can happen within 12 hours of having unprotected sex. Now they're a zygote. That zygote will undergo rapid replication, and it'll become something called a morella, which is a solid ball of 16 cells, which will just divide and make specialized cells. And those specialized cells include the blastocyte and the trophoblast. So we're going from conception immediately. Once the egg and the sperm meet, they are a zygote. Once they are defined as zygote, or the egg and sperm meet, it's going to go under rapid cellular replication, do a bunch of things, make that morula of that solid ball of 16 cells so we can get the blastocyte and the trophoblast. The blastocyte and the trophoblast develop around 7 to 10 days after consumption. Conception. So even though it became a zygote immediately, it takes a decent amount of time for the specialized cells to occur and to have the blastocyte and the trophoblast. So the blastocyte is what becomes the embryo. That's what becomes the embryo, which is day 15 to week 8. The trophoblast is what becomes the placenta or the chorion. And both the blastocyte and the trophoblast bind to that uterine wall. So it's like the blastocyte first, and then the trophoblast on top of it. And by the time the trophoblast and the blastocyte bind to that uterine wall, right, which is about now almost 15 days after conception, once it hits that 15-day mark and the blastocyte and trophoblast bind to that uterine wall, now they're an embryo. They're considered an embryo from day 15 of this whole process to 8 weeks. After that 8-week mark, right, during this embryonic phase, right, when they're considered an embryo from day 15 to 8 weeks, there's a lot of organ development. Once they get past that 8 weeks, now they are a fetus. Does that make sense?
Yes, it does. Thank you so much.
Okay, it's a lot. She's definitely going to ask about all of these things. But yeah, and definitely remember that the trophoblast and the blastocyte, right, are going to be able to bind to that wall 7 to 10 days after conception. So it's going to happen between that time frame and knowing when to call an embryo, which is day 15 to week 8. Okay. So auxiliary structures, or structures that help with the pregnancy. We talked about how that trophoblast becomes that placenta, which is so important to the baby, and the blastocyte is the embryo or the baby. The placenta is almost like an exchange unit between the mom and the baby. And its most important function of the placenta is that it serves as respiration and gas exchange through simple diffusion. In other words, it gives the baby ability to breathe. And you'll understand why they can't breathe on their own a little later. It can also give the baby oxygen, nutrients, as well as removing waste products. So the placenta is really important. But one of its most important functions is respiration and gas exchange. Now, there's also hormones that need to be released during this. So while the baby is sitting there and it's getting nutrients and oxygen and respiration from the placenta, we have a bunch of different endocrine things going on. We have that human chronotropic gonadotropin hormone. As I said, this tells me, hey, I'm pregnant. If you pee on a pregnancy test and it says positive, it's because you have this hormone present. How do we know? Well, if they do a blood test to see for this hormone, we could see it 2 to 3 days after implantation. And another really, really important fact is that this level, whatever it is, must double every 48 to 72 hours. So she could ask you a question and say, okay, the patient comes in, let's just say the value is 10, right? 2 days later, she comes back for blood work and it's at 12. That's not good. That means there's something wrong with the baby. It needs to go from 10 to 2 to 3 days later to be 20. And then it needs to double and double, okay? Another way you could check is through the urine test, which takes a little longer, usually about 2 to 3 weeks. And you typically see this hormone doubling, especially we want to see that in that first trimester. After that, it starts to decline, but we need it in that first trimester to show that this baby is thriving. The next thing is progesterone. We already spoke about it a lot, but you can see this is an important hormone and that she's going to ask questions about it. It facilitates implantation. We understand how important that is for the baby to develop. Made in that corpus luteum that we spoke about before. It has hyperthermic effects, right? So increased temperature, GI effects, so constipation, hemorrhoids, breast development, right? That's why a female's breast would typically get bigger in size, especially when they are pregnant. And it decreases the contractility of the uterus. So it helps allowing the uterus to expand without trying to push the baby out unnecessarily. Then we have relaxin, which is a hormone that we have within the body that helps regulate the mother's hemodynamics, like her blood pressure and heart rate. It's a vasodilator, relaxin, right? We remember vasodilator means, things drop. So if, let's just say, during pregnancy, the blood volume increases, this hormone's going to release to help contract the body's increase in blood pressure, increase in heart rate. It's going to decrease them because it's a vasodilator. And it also helps dilate the uterus during childbirth. Estrogen also plays an important role in the enlargement of breast, the uterus, and external genitalia, and it enhances uterine activity as the due date approaches. The human placental lactogen hormone, I would just know for this is that it supports lactation, helps the baby, helps the mom produce milk for the baby. And prolactin also has a role in lactation. So if you can't really remember, you could say lactogen, prolactin has to do something with lactation. Another thing that the placenta can do metabolically is that it can synthesize into glycogen, cholesterol, and fatty acids. So it could take substances and combine them into these things for the baby. I remember seeing a select all that apply on my exam that had to do with what does progesterone do and what does the placenta do. So I would really heavily know that, and that its primary or most important function is respiration and gas exchange, and I would know what all the hormones do. The next, some other structures that we have is the amniotic sac, is what the baby sits in. That's really important too. And it contains amniotic fluid. And there's two parts, the amnion, which is that inner membrane, which is with the baby, and then we have the outer membrane or the chorion. So, this is another protection for the baby to grow and develop in. And remember, we said the chorion is built with that tropoblast. So, and the amnion is built with the blastocyte. So you could see where these things are coming from based on understanding the idea of the whole zygote conception thing. Now, amniotic fluid. Well, what's the importance of that, right? We have an amniotic sac filled with all this amniotic fluid. Well, why do we really need it? Well, one, it provides thermoregulation for a fetus. As you will know or begin to learn, is that temperature regulation for a baby is crucial. If the temperature goes out of whack, their respirations can go out of whack, and so can their sugar levels. So it could be very detrimental for a baby. It allows for symmetrical growth and development of the fetus. It cushions and protects the fetus, and it protects the umbilical cord. This is why we need amniotic fluid. It will increase in volume throughout pregnancy. Makes sense, right? As the baby gets bigger, we need more fluid, and it must be up to 1,000 milliliters by 34 weeks. Also, um, basically, the source or like what this is made up with is pretty much blood and the baby's urine. So that's the primary source of this amniotic fluid is the mom's blood and the baby's urine. But I would definitely know what it does, right? What are the four key things that the amniotic fluid does, how much ml you need, and what it's comprised of. Now, other important terms that you need to know, like I said, we said that we need up to 1,000 milliliters by 34 weeks. So we have two problems. Um, oligohydramnios, I don't know how to say that, and polyhydramnios. So oli means, remember, like oliguria, right? Not enough urine. So oli this means not enough amniotic fluid, so less than 500 ml. This does not allow for symmetrical growth and it can cause fetal distress. Polyhydramnios, or too much amniotic fluid greater than 2,000 milliliters, can put the baby into risk for preterm labor. So we see how important it is that this amniotic fluid stays in a certain number because it could either affect the growth and development or cause preterm birth. Now, the umbilical cord is really important because it also provides oxygen and blood supply to the baby. So the umbilical cord, she's going to ask this. I remembered AVA or AVA, artery, vein, artery. There's two arteries in one vein. You must know that. And that it's surrounded by something called Wharton's jelly, which basically protects these arteries and the vein from compression. Is there any questions about anything we spoke about? Okay, I take silence as no. As I said, if you haven't already, make sure to put your SFC ID number into the chat. But okay, so another important thing is fetal circulation, right? We talked about the placenta, it gives oxygen. Yes, we have the umbilical cord, right? But like what's going on? Like why do they have a placenta for respirations? Why not just breathe on your own, right? Like any other human would. Well, interestingly, blood is going to leave the placenta and go through that in umbilical vein to get to the baby. So unlike how in our bodies, right, arteries are what gives blood and oxygen to the rest of our body, it's the umbilical vein that's going to be giving blood to the baby. After circulating through the fetus, the blood returns to the placenta via the umbilical artery. See the difference? It's the opposite of how an adult or how we would receive blood, right? Because normally veins bring it back to the heart. Nope, it's the arteries this time that are bringing it back to placenta. So it's different. So remember, umbilical vein means the blood is going from mother to fetus. Any deoxygenated blood is going to go to from those arteries, from the fetus to the mom. Now, fetal circulation, as you could see, is different than ours, but it's also different because it has something called shunts, which basically means that it shifts blood from getting to certain places, particularly the lungs and the liver, because they're non-functional while the baby is being made. So we have this ductus venosus, which means that it shunts blood flow from the umbilical vein directly into this inferior vena cava of the heart and bypasses the liver. So in other words, in this ductus venous, it goes straight from that vein to the part of the heart and doesn't go to the liver. So the liver is inactive because of this shunt. The next shunt that we have is foramen ovale. Like imagine it means kind of like a hole. This allows blood to go from the left atrium to enter the left atrium from the right atrium. And in doing so, as the blood is going from the right to the left, it doesn't even need to go through pulmonary circulation, which means the lungs aren't getting blood supply, so they're useless. The ductus arteriosus is a shunt that's between the pulmonary artery and the aorta. This allows blood to go from the right ventricle all the way to that pulmonary artery to the aorta without directly affecting the lungs. She will definitely ask questions about these three shunts. But the moral of the story is that the placenta, remember we said respiration and gas exchange, the lungs are not doing that for the baby. Any questions? No. Okay. Okay. So the next thing that we have is the embryonic stages. We said the embryo or the embryonic stage will be from day 15 of implantation to the end of week 8. Okay, after week 8, starting week 9, they're a fetus. Okay. Um, so we said the embryonic stage is where organs are developing. And during this phase, which is that early trimester of pregnancy, the babies are most vulnerable to teratogens or anything harmful. Teratogens are just another way of saying harmful things to the baby. That means alcohol, tobacco, cocaine, polluted water, medications, right? Medications can be harmful. Remember when I kept saying in pharm, everything's pretty much contradicted in pregnancy? Well, it doesn't leave when we're talking about OB. Medications can be negative to the baby. Sugar, remember I said sugar is a problem not only for, let's just say, gestational diabetes or diabetes that you get when you're pregnant, but also if sugar is too high, you're going to learn that it can affect the baby's ability to regulate their temperature and also their ability to breathe. So sugar is very hazardous for a baby, and any sort of environmental hazards. Those are all teratogens. Um, it all depends what could happen to the baby, all depends on the exposure, amount of time, things like that. That's why we always say, hey, don't drink, don't smoke, don't do these things. Ask, your doctor if you're going to take certain medications because we don't know the extent of what that can do to your baby, even just the smallest amount. Now, another really, really important teaching point is that folic acid. We tell even pre-pregnant women to take folic acid before planning to get pregnant because it helps prevent spina bifida, which is a spinal abnormality in children. So we always recommend that to women of childbearing age. Okay. Now we have the weeks. Like I said, this is more of a memorization thing. I'm not gonna really I'm just gonna read it through quickly, but you will need to know whatever weeks I might have more on here. I'll be honest with you, whatever weeks she has on your PowerPoint, I would know them. Just know, um, trying to think. In week 6 for sure is fetal circulation is established. Remember I was talking about all those shunts that we have in the body? Well, in week 6, this is where it occurs, and we also have lung formation. Another thing that I want to point out is that fetal period that someone was asked, when does the fetus come? Right after week 6, week 8, all the way till birth. Weeks 9 to 12, you're able to detect a fetal heart rate through a Doppler, and the baby's able to produce urine, and it could even be excreted. By 17 to 20 weeks, Langot or fine hair is developing on the baby. And they're also getting something called Vernix caseosa, which is a white substance on the baby. She is going to show you a picture of these two things and ask you which one is which. So remember, Langot is hair and the Vernix is white substance on the skin. And the point of these things is to protect the baby's skin from the amniotic fluid. That's why sometimes when baby's born, they have so much hair and they have white stuff. That's to protect them from that amniotic fluid. Remember, it's basically pee. So it could be harmful to the baby. Another important concept is quickening, which is usually perceived, it must be perceived by 20 weeks, but it can be perceived as early as 12 to 3 weeks. This is when you can correct me if I'm wrong, if you have something different in your notes. I believe quickening is when you first start to feel the baby kicking. Someone can correct me if I'm wrong. But that's what I remember for that. Yeah, it's baby movement. So you could feel it as early as 13 weeks, 12 to 13 weeks, but it must be felt by 20. She's going to ask you that. I would also know, I would definitely know all of these in your notes. I'm pretty sure they're in your slides, but I would know them. And I would know that after 33 to 38 weeks, the fine hair, that lango, starts to disappear and the vernix starts to go away too. But like I said, that's more of a memorization thing. I can't give you any tricks other than she is going to ask questions on the weeks. So just only, even though the textbook could have more, only focus on the weeks that she has in her slides. Okay. So the last thing, which isn't really, it's a decent amount. We'll see how much we can get through. Hopefully I can be quick. But the next thing is signs, pregnancy signs. There's actually a few different things, and you'll actually see this come up on your ATI, the different types of signs. So presumptive signs means this makes the mom think she's pregnant, something she feels. So maybe she feels more tired. She notices she doesn't have her period anymore. She's nauseous and vomiting. She has breast changes. She has maybe quickening, right? She feels some sort of movements and skin hyperpigmentation. Anything that she feels, right? Maybe going to the bathroom a lot. It's subjective. It's what the mom feels that makes her think she could be pregnant. Probable signs are signs that would let the examiner know, I think she's pregnant based on my examination, but it's not a like guarantee. So what we might see, one of the things would be changes in pelvic organs. So I would know these three signs: Chadwick sign, which is this bluish cervix color; Goodell sign, which is the cervix is softening; and Heger sign, which is softening of the uterine lining. Abdominal enlargement with changes in the uterine size and position can also be. Braxton Hicks contractions, which are just intermittent contractions that she might feel. Velotomy, which is basically when the examiner feels rebound pressure after pushing down on the cervix, can also be a sign, or a pregnancy test, positive pregnancy test. Like I said, HCG can also be released falsely during things like ovulation and things like that. So sometimes pregnancy tests can be unreliable. That's why it's not a positive or 100% accurate sign. 100% accuracy, or I could say I know she's pregnant, is I used to use this little like acronym called FAV, FAV. I did the for movement, CN movement, A for rotation, a heart rate, and V for visualization. I could see a baby on some sort of ultrasound. Now, we talked about pregnancy tests. We talked about its HCG, that hormone, right? We want to do the first void of the day. And there's two ways that you could do it. There could be the urine test, which would be 2 to 3 weeks after conception, about 95% accurate, or the ELISA, which is a blood test, and it's reliable 4 days after implantation, and it's 99% accurate. Remember, we're looking at HCG. That tells us if they're pregnant. That's the hormone that tells us that. And it has to double, like I said, every 48 to 72 hours. And it should be, when they take that level, it should be greater than 25 mLu. I'm not sure what that U stands for, but it's supposed to be greater than that. But no, whatever that number is, she's definitely going to give you a question where it's like, oh, the patient comes in and that HCG is like, let's just say 30. She comes back in 3 days. If that's not 60, there's a problem. Okay. And this HCG basically doubles during that first trimester. Now, there's a lot of changes that go on in the body when one is pregnant. One is that we have Braxton Hicks contractions, which are these spontaneous, random, irregular, usually painless contraction-like feelings that she'll get, usually more noticeable in that third trimester, and that Heger sign, which is that softening of the uterine lining? Yes. Also, fundal height is going to change, or meaning how high the stomach gets or how big it gets, right? So at 36 weeks, it should be at the exvoid process, or basically really close up to the ribs. Usually we start doing fundal height around 18 to 32. But at 12 weeks, the fundal height is usually near the pubis. At 16 weeks, it's going to be midway for a singleton pregnancy. And at 20 weeks, it's going to be at the umbilicus or like your belly button. Okay. Know those. She's going to ask a question on that about where the fundal height should be based on different weeks of gestation. And lightening is a term that means between 38 to 40 weeks gestation, the fundal height drops. So when instead of the stomach sort of coming up, it kind of falls down, which puts pressure instead of on the respiratory system, it puts pressure on the bladder, making them want to pee more. I see a question.
Yeah, hi Alicia. I have a question. So you said she probably gonna ask us a question like about the thunder high, but I wanna know, is she gonna ask a question about if it's at the belly button, at the pubic area, or like is it gonna be maybe 32 centimeters, and what thunder height is that? You know what I mean? Because 32 centimeters will probably be like 32 weeks. But is she going to ask like the name of the region of the stomach, or she's gonna ask us specific numbers?
I think
You know what I mean?
yeah, I think she gave a picture because I think it's the centimeters correlate to the weeks if is that if I remember that correctly. I think she might give a picture and she might show an area and say like which week do you think it is or which of like out of the options which of the following would be an expected fundal height for somebody at 12 weeks. So I would know, oh, it should be at the pubis.
Right.
Or at 36 it should be at the exvoid process, like things like that. I'm pretty sure it was like only like one or two questions if anything, but definitely know this. I don't remember if she asked anything about centimeters, but it wouldn't hurt to know that. Okay, so a lot of other changes happen too, right? They're gonna have hypotension. Why? Because there's a huge baby growing in your stomach. And in return, it's putting pressure onto all of your organs, including the body's ability to have cardiac return, cardiac output, and blood pressure. It's going to press on that vena cava, and in return, it's going to cause decrease blood pressure as she's laying down. That's why they call it supine postural hypertension. So when the mom's laying, right, that pressure of the stomach, if you're on your back and you have a big belly, where is all that pressure going to? All of your organs, which some of that includes your heart and your heart's ability to have cardiac output. So what do we tell them? They must lay on their side. Do not lay on your back. That's your teaching point. Do not lay on your back because they could have postural hypotension. So that's what we're telling them. And to use pillows when they sleep, so to help alleviate pressure. Cervix, we talked about those signs, right? Goodell's sign, which is a softening the cervix, and Chadwick's sign, which is that bluish discoloration. And we also have a mucus plug, which is this white mucus that acts as a barrier between the outside world and the fetus that we could see the mom producing, as well as if they have a leukohera, I don't know how to say that word, but if they have increased white vaginal secretions, that's normal during pregnancy. Breast, tender, they feel full, they're enlarged, and we expect to see colostrum by the third trimester, which is later down the line, this sort of thick, white, pale, yellowish fluid that's really, really high in protein, fat, antibiotics. GI, during that first trimester, we see that nausea and vomiting because of what? Progesterone. Remember we said it has GI effects, and HCG. I don't know if she told you guys this during the class, but for us, she told us that For nausea and vomiting, the only FDA-approved drug was doxylamine succinate, 10 mg, or pirexidine hydrochloride, 10 mg, to treat morning sickness.
Can you put that? I don't think I can.
Say that again?
I said if you could put it in the chart. I don't. Oh, I see it. Never mind.
Yeah, I'll send a picture because it's definitely a long. This is the only approved medication for motion sickness, for patients who are pregnant. Other GI symptoms that you'll see, but not in the first trimester. So nausea and vomiting is particularly a first trimester problem. Then we have heartburn, constipation, and hemorrhoids, typically seen in the second and third trimester. The gallbladder is also affected, and as a result, it becomes hypotonic and it's not really able to delay. And it's hard to empty. So because the gallbladder can't do that, there's an increased risk for gallstones because things are going to start building up because it can't empty out. Now, remember how we were talking about relaxin, that hormone that helps regulate the hemodynamics, the heart rate, blood pressure? We have that hormone, and it's important because during pregnancy, the blood volume increases. That's because we're trying to support a life. And the RBCs increase by like 450 milliliters, and the plasma increases by 1 liter. And plasma's everything: red, white blood cells, and platelets. So because of this increase in blood volume, up to 50%, we could have something called hemo dilution, or what will lead to physiologic anemia of pregnancy, because there's so much more plasma than there is in RBCs. So we said there's 1 liter of plasma versus only 450 ml of RBCs being produced. Those hematocrit and hemoglobin levels are going to decrease, which can result in anemia. So if a patient becomes anemic, they need iron, right? And this is where we tell them, hey, make sure if it's liquid, drink it through a straw, right? Drink it with orange juice because it increases absorption. Dark green stools are normal, and no milk and no antacids. Cardiac output increases, right? Because of that increased blood volume. And relaxin prevents the heart rate from increasing too much, and it keeps the blood pressure stable. See, everything just comes back around. So we can expect the heart rate to increase 10 to 20 beats per minute higher than her baseline. We also have a decrease the BP is going to adjust differently throughout the period of pregnancy. First trimester is not going to be affected too much. In second trimester, the diastolic or the blood pressure is going to decrease a little bit. And in third trimester, it's going to increase a little bit. So what are some things that we also see? Vital signs, right? If progesterone is helping to maintain pregnancy, we will see an increased temperature, increased heart rate because of the blood volume, but we expect a stable blood pressure and stable respiratory rate. Know what you are expected to see for vital signs of a pregnant mom. Pregnant moms also are at very high risk for clotting, okay? So they have an increased risk for clotting, which means we don't want pregnant women to sit too long because they're at increased risk for venous stasis, okay? So remember, pregnancy also means, hey, clotting's going to go up, so we want them to move more. Respiration, right? As that stomach increases, there's pressure that's going to the lungs, so the mom needs more oxygen needs because there's decreased space for the lungs. For renal, we already spoke about that first trimester, lots of urinary frequency, and that last trimester, remember, 38 to 40 weeks, that lightening, right? When the fundal height drops and it puts pressure, instead of all the way up here on respirations, it puts more pressure on the bladder, so they pee more. Also, UTI frequency increases in the second trimester. We don't want to see proteinuria, but mild, like a little bit, is not too concerning. Sugar in the pee, even though normally it would be concerning, is not too concerning for a pregnant woman. And straw-like urine is also common. They could have changes in posture and gait, right? Because if you got a big stomach, you might have a hunchback a little bit. You might get lordosis or a little bit of like lumbar spine curvature. Lastly, for integumentary, some things that we'll see is that they'll sweat a lot. They'll have hyperactive sweat and sebaceous glands, so they're oily and sweaty. They have hyperpigmentation. Remember we said those presumptive signs of pregnancy, hyperpigmentation. Usually we'll see that at about 24 weeks, and there's something called we might have a linea nigra line, which is basically a line in the middle of the stomach that stretches to the pubic symphysis to the umbilical. So basically from your pubic to like your belly button, like a blackish line, a purple blue line, that's normal. There's also chloasma or melasma gravidum, which is basically dark spots all over the face and forehead, blotchy spots of pigmentation. That's okay if that's on the face. Stretch marks or striae gravidum, very normal. Very normal. That reddish on the abdomen, breast, and buttocks. We expect to see those things. She's definitely going to ask about that too. And she does ask about changes, especially in tegumentary, especially clotting, renal, cardiac, and GI. And you know those cervical signs are a part of some of the things that we spoke about before, so you will see that too. But those, big emphasis on those. You must know your CBC values for pregnant women. You could take a picture of this, but it's also in the back of your textbook in Appendix A. Write those down and know them. Because the signs or the CBC values for a pregnant woman are slightly different than those of a non-pregnant person. Did she go over the nutritional needs with you guys for pregnancy?
Yeah, she did.
Okay. So I'm just gonna like run through this really quickly. But you need iron, and you need 27 mg of iron because iron makes hemoglobin, which is really great for oxygen. More iron means more oxygen for the baby. So we need iron. We want to tell them to increase iron. Folic acid. Know how much MC or mg to give daily. Why? Folic acid prevents spinal bifida and neural tube defects. So we need at least 600 mcg to prevent neural tube defects. Pregnant women, they always say, oh, they need to increase their diet so much. They can eat a lot more. Pregnant women are only expected to eat 300 calories more per day than they normally would. They should also increase their protein to 60 to 80 grams a day. For a normal pregnancy, a singleton or a one baby pregnancy, she should gain 25 to 35 pounds. Know that. What else? What we said, 27 mg of iron. We talked about how much folic acid. We need calcium for the baby's bone and teeth. We need 1,000 mg of calcium for all women ages 19 and older, and 1,300 mg for calcium for women aged 14 to 18. We can get this in milk, dairy, broccoli, dark greens, leafy vegetables, sardines. If you're good at nutrition and stuff, good, because she definitely will ask a question, maybe which diet would be, recommended for a high calcium, or what would you need for someone? She's definitely going to say something like, oh, how much calcium should the nurse recommend for a patient who's over 20? And she will want you to know those numbers. Caffeine, no good. Coffee, all of that, not good for pregnancy. It increases the risk for miscarriage. So we want less than 200 mg, or 1 12-ounce cup of coffee is safe a day. No more than that. They have to be very, very careful with caffeine. Fish, great. Good for the baby's brain. 2 servings of fish of about 8 to 12 ounces, great. Good fish, shrimp, salmon, catfish, pollock. Bad fish, shark, swordfish, king markle, marlin, orange roughy, tidefish. And limit tuna to 6 ounces a week. This is all memorization, unfortunately. I would know that listeriosis is a type of foodborne illness caused by bacteria that you can get from certain foods and can result in miscarriage or a stillbirth or even premature delivery. So that includes unpasteurized milk or foods, hot dogs, luncheons, cold cuts, unless they're heated. Plate meat spreads, smoked seafood. I would just know what listeriosis is. That's a type of foodborne illness. The last thing is maternal responses to pregnancy. So during the first trimester, it can be a little weird, right? Like you just get told you're pregnant. You might feel ambivalence, really surprised. You might be uncertain. You're more focused on you, like, okay, how am I gonna handle this? In second trimester, you're more about focusing on the baby and you're making baby plans, okay? But they could have body image issues. So that's something that we see in second trimester. So first trimester, it's like, I don't really know how I feel. Second trimester is like, oh my God, the baby's coming. Third trimester is they may question their ability to parent. The partner's perception could be altered. And we're preparing for childbirth. Mood swings, usually characteristic, it's not going to be so crazy different. And something that I know that she did ask about partner's response is something called KUVAD, which is when the partner feels like they're pregnant too. They almost feel the symptoms that she's feeling while pregnant. Okay. Is